Yeah, so I'm not gonna happen.
Where'd you get that positive t-shirt? It's like on the video.
Oh shit. Well, at least I'll keep my swearing in a minute.
Hey, that's what it looks like when you aren't mirroring. Just don't judge me. I use the notes even when I'm around people I know.
This is a judgment-free zone.
Oh, I'm judging myself. Don't worry. Oh, yeah, wife. Judgment always. Okay, so a lot of you in the room already know me, but my name is Luke Morris. I've been at Cedars-Sinai's emergency department as their data guy for 3.5 years at this point, and although we just had an introduction about the cool stuff that I did for my master's program, I'm not ready to present that for the public yet. So instead, we're going to look at some of the other cool work that I am able to help with, and that is looking at our homeless patients and how we are expanding their access to healthcare beyond just the symptoms that they come into the emergency room. So quickly, here's a look at what's on tap. We're going to look at homeless figures in LA, the role the emergency department is designed to meet, how those two things don't always line up, a new role we created to tackle those issues, and how all of that is going. So, there's a lot here. I'm not going to drag you through all of it, I promise. But here's the highlights. 0.2% of the US population was experiencing homelessness in 2020. Post-COVID, that number's only gone up from the 580,000 seen here. If you zoom in, 12% of Americans live in California, but 28% of all Americans experiencing homelessness live in our state.
Mm-hmm.
And if you zoom in even further to LA County, we're home to 25% of California's population, but 41% of Californians experiencing homelessness reside within the county. Even further, looking at 2 of every 5 LA County residents is within the city of LA, but 3 of every 5 experiencing homelessness in the county resides in city limits. And COVID is expected to have left another at least 20,000 Angelinos homeless. And you can probably see, you might see here at the bottom that I'm using 2020 numbers for the loss account because the 2022 one had some interesting methodology. All right, so with the background of homelessness established, let's look at what emergency departments are actually designed to do. So it's best known as a community safety net for anyone seeking aid, and there's actually a law called EMTALA, and if I were good at memorizing things, I would tell you what it stands for, but basically that ensures that no matter what you come in for, what your immigration status is, what your insurance status is, if you come in, you can be treated. But emergency departments are designed as more or less a midway point in your care journey. So the idea is that you get stabilized good enough to either go back home safely or to be admitted to some kind of specialty floor to have more specialized treatment. So recent decades have seen the ED model tested and challenged by growing non-urgent utilization. And the results of that are that the ED resources get spread thin, everybody's wait time balloons, which I'm pretty sure a lot of us have experienced. If you haven't experienced, haven't had to be in a waiting room in a while, congratulations for not needing to be in a hospital. But the waiting time has ballooned with the influx of patients, and people are starting to leave without being seen because they're just tired of waiting. But like I said, some of this is like over a decade old, some of these issues. So we've been seeing overflowing waiting rooms and gurneys lining hallways. And a lot of the non-urgent cases of people coming in for minor things are the culprit. Folks are trying to get their prescriptions filled at the ED, poorly regulated blood pressure or blood sugar cases pack the waiting room, and many behavioral health patients stop by the ED essentially as part of their social routine. All through this, staff are getting spread thin. That drain on energy and burnout puts both the staff and patient at risk. And like I said, all of this was an issue even before COVID. Mm-hmm. So one thing I need to do really quick. Okay, sorry. One of the patients behind One of the patient groups often behind these low acuity cases are those experiencing homelessness. And here's what the homeless caseload looked like in our ED. From February 2020 to January 2021, our neighbors experiencing homelessness visited nearly 8,000 times. And the average rate here suggests that we saw each one of them about 2 or 3 times, but the reality is that some of them were seeing dozens or even more than 100 times. So there were a good number of outliers. So common chief complaints we see in those visits are food needs, seeking shelter, and treatment for issues best handled by a primary care physician or an urgent care. And it's not just the homeless population that is using the emergency department that way, but there is a lot that we can unpack, that we don't have time to unpack. So let's rewind a little bit before COVID. In 2018, California passed a law requiring hospitals to document the types of services and resources offered to patients experiencing homelessness before discharging them. So a lot of times you are filling out a checklist and you're seeing were they fed while they were here? Did they get a ride to where they stay? How about, did they receive meds, vaccinations, help applying for insurance? Were their clothes appropriate for the conditions outside? Were they set up with a follow-up appointment with a primary care physician or a behaviorist if that was what they needed? All of these things need to be noted before a patient is discharged from the hospital under California law. So obviously the status quo wasn't meeting our homeless patients' needs, and our ED leadership started wondering if there was something being missed in the initial encounter with a lot of our homeless patients that could limit the need for return visits. And somebody was going to need to track all those new data points anyway, so a generous donor was able to help the ED create a new role, the Community Resource Coordinator, and they are charged with going beyond the symptoms with our patients experiencing homelessness. If patients welcome a CRC's help during their visit, the CRC works on connecting them with vital staple needs or shelter or health coverage or follow-up care. By the way, the person you see here is Wayho, and he is one of the original CRCs in our program. He's since left, but a lot of what I am presenting, the target variables here you see are his brainchild. I just happen to be the one who crunched them with R. So,
Do you want questions during or after? During the presentation or after you're done?
After, if that's okay. All right, so here's kind of the research question that I ended up approaching. Are CRCs effective at reducing the use of emergency services for non-urgent matters while ensuring that homeless patients can access their basic needs? Luckily, we've got a data set to help us figure that out. So we tested a diff and diff cohort model to compare the visit rates of patients experiencing homelessness. One group saw a CRC at their index visit, or the original visit. One group didn't see a CRC on that visit. Across groups, we compared how long it took a patient to return to the emergency department, the cost of their stay, and the length of stay, and ran each through its units. When it came to gap between return visits, we indeed found statistical significance. Patients who saw a CRC took an extra 3 to 11 days to return compared to those who don't. So from there, we got a little bit more curious, and we compared visits per 90 days and per the next 180 days. And we saw patients who met with a CRC had 1 to 2 fewer visits in that window of time. And here's a look at the 180-day return rate. So those differences for cost and length of stay didn't quite work out. We couldn't achieve statistical significance there, but upon reflection, that kind of made sense, because a CRC, the way we have that role set up, doesn't necessarily have any sway in what treatment somebody is going to get or when you receive it. So yay, we've got a few p-values to go our way. But what does that mean? The big win comes in the fact that we know these patients are getting connected to community resources that they need. They're getting opportunities at follow-up care that go beyond the symptoms. Meanwhile, in the emergency department, the possible gains are cuts in wait time for everybody, fewer patients heading for the door before being seen, and emergency providers getting to do a little bit more of what they entered the field to do originally, which is save lives in immediate danger. We've continued monitoring results beyond that first year of the program, and things continue to look promising for reducing repeat visits. So a lot of those numbers are very similar to what we had presented originally. And I'll go ahead and take questions now.
How do you know a patient is PEH? Is that the term?
Whether they're homeless or not,
Yeah.
it's really complicated because it's self-report for the most part. And it's also really awkward because a lot of them don't want to either say, hey, yes, I'm homeless, or they don't want to say, yes, I'm homeless, out, in the waiting room, or, where they think that other people might be hearing,
Right.
or, they're in denial about the situation, or who knows what. But a lot of it is self-reported, so everything presented is more than likely an undercount, and it's kind of, we study what we can,
Right.
so.
One more quick question for you.
Yeah.
So you were watching this whole thing unfold. Were you a part of the original discussion about formulating the data science project itself, or did management really just come and kind of drop some of it on your lap? How did that work?
So the data set that we have, basically that came out of the necessity of that SB 1152 law. So a lot of the data that we have, like I actually have right here, that was actually perfect transition, is
Okay.
like the patient identifier, the encounter identifier, when they arrived, when they departed the emergency department. If they saw one of our CRCs, that field will have the CRC's name in it, otherwise it will be blank. And also charges, as well as visits for the last 90 days or the last 180 days, along with other identifiable things that, I can't necessarily share.
So ED Navigator, that's i.e. CRC.
Yeah, sorry. I think I was looking at the sheet as I was typing that out. John?
Did you make any distinction between the different types of homelessness? Like I would assume that somebody that was recently evicted from a car is very different than somebody that has a serious drug addiction that's been on the streets for a decade.
That was not necessarily tracked. I don't think there's a great way to do that, but social determinants of health are a really big topic in healthcare right now, and
That's why.
also the idea of housing instability itself. We're starting to get better at understanding the spectrum of that entire issue.
Those total charges, is that to the insurance company or to the patient, or just
It
how
is-
much it costs? For
Yeah,
the
it is what would be charged for the everything that was being done.
Okay.
Go ahead.
Quick question. Under the CRC notes, do they say what sort of services were engaged when they left?
Yes, we've actually, before Weho left, he actually created a new sheet that, there was a bit more of a tier of what they were offering. So it was hey, it wasn't just necessarily, we got this person X or Y. It was, we gave him these and we gave him that. And just kind of a better idea of how, I think we had tier 1 was basically they told him to get lost, and it kind of just went up from there.
I don't know if you know the answer to this, but how does something like Medicaid work for someone that might not have access to managed care or a phone or internet? What did you say the law was in 2018 that was filed?
SB 1152.
Okay. I'll look into it. No.
Yeah, I'm not.
I'm just.
Probably not the expert to be speaking on that.
Yeah, no. This is good. Thank you.
Was this an internal data set or from HTI or?
This is internal.
Uh-huh.
It's literally, the patients come in, and I get a version of this every day that I send to our nurse managers. I'm like, hey, here's people that the CRC may want to, take a look at when they come in. And I also get a monthly version, and that is kind of what we keep and run the stats that you saw before. And if you want, we can look at the actual script that I use for the report here. So we've got some dplyr and some tidyverse. Call in our Excel sheet. This is also part of the version on the group GitHub. So is it not showing as I'm scrolling? That's weird. Go over here and scroll. Okay, that's neat.
If you hit F, I think it might go into full screen if you want that. Yeah, just a little bit. Yeah.
Everybody's learning new things about Quarto every day. So yeah, this is just me toying with the Libre date to get the dates the way I want them because I'm very pedantic. And then this is also measuring our Marina Del Rey emergency department. So basically I'm having it look at patients who were either came to us through our emergency department in Beverly Hills or through the Marina Del Rey one. So anybody who came through like an outpatient visit for something else, we're not looking at that at the moment. And this is more Libre date hackiness that gives me, you know, the way that I'm able to just like go and say, hey, give me last month instead of having to like manually type a bunch of dates in. And glue is my new best friend. And this is how I get a lot of the preformed text that comes in. And you can see that a lot of those variables are here within the curly brackets. And that's, it fills in things for me, which makes me happy. And I'll skip over really quick so you can just kind of see what it looks like. So it fills in the number here for the number of interactions. And so even tells you like the dates.
So similar to our markdown.
Mm-hmm.
With that, yeah.
And it actually,
I love that stuff.
so for these groups, it actually goes through and
Is this a report you provide to someone else, or is it for you?
yes,
Yeah, I was just about to ask, who's the end user for this?
it is my boss and our community benefit team, as well as the CRCs themselves.
Nice.
And why does it suddenly hate me? But,
I love reproducible reports.
oh, hey, I just had to hit escape. Cool. Yeah, I also kind of like put in the little explainers for people who are not stats folks, so that when they're looking at the graphs, they know what they're seeing. This is another favorite thing from Libre date, so you can basically make
Yeah, what is that?
intervals.
So,
So basically it's saying, give me
Or
an
what-
interval where this is the start time and this is the end time.
huh? What is that pipe? Is that a pipe?
Yep.
It's part of Libre date?
Yep.
Very cool.
It was a lot of Googling because I definitely did not know that myself. And yeah, this is kind of going through, here's a simple old, plain old t-test is what shows, what does all these statistical rigor, and then eventually we get to
Yeah, I'm making a note of that pipe
visualizing.
because I'll forget the next time I have to try to use it every day.
And look, somebody will be happy I actually did the error bars with standard error. But that was pretty much what I got. We can take another look at the final result. And so literally like, you know, the first of the month when I get the new data run, I can just hit render and I get all of this. And it makes me happy.
Is your data pretty clean coming in, or do you have to do a bunch of
No.
munging? And I was just curious. I'm like, you're skipping a lot of steps here. And you're like, look
Yeah.
at my gorgeous data set, and I'm just going to run this script and get a new report.
No, there's a lot of cursing behind the scenes,
Okay,
but
that warms my heart and brings me some solace.
no, this was like something that I worked on for months. And like, if there's ever been something like at work that I've been able to like steadily build on and build on and build on the way that apparently real data scientists do, this is the closest thing. So it's kind of pretty.
Do you have access to Power BI or anything? I'm just because right
Tableau.
now are you Tableau? Yeah. Oh, that's right. We talked about this.
It's
okay.
fine.
Yeah.
It's fine.
Yes.
It's fine. No, really. Are there any other questions? Yeah.
Yeah, so when when you did your two sample where it's like wasn't seen by CRC,
Mm-hmm.
saw by CRC, was it like Like that CRC person, did he like flip a coin and said, okay, I'm gonna shoot if it's heads, I'll see him, and if it's
It wasn't, done like, like a RCT or anything. It was, who was there when the CRC was there, because it's not a 24-hour job.
okay.
So I think most of the time the hours are like 10A to 6P. So a lot of times, if a patient left overnight or something, they probably weren't able to see them. And especially like during the winter months when it's a lot of seeking shelter as well as like trying to get treatment, there can be like too many to see in a shift.
Okay. Thanks.
Could we have another look at that lubricate function
Yeah.
that you pointed at?
You talking about the one that made
the
an interval?
length or the int underscore length?
The weird pipe,
Yeah.
the eye-opening pipe for the night.
Yeah, I'll pretend I know exactly where it is.
Yeah. It was percent dash dash percent.
Yeah, exactly.
It's probably because I'm trying to look backwards. Actually,
A little bit up, I remember it was before your plot. Oh,
Oh, there you go. Yeah.
hey. So yeah, it's int length, and then I'm saying that I want discharge date to be the start of my timestamp, which yes, it's called date, but it's actually a date time. Sorry, that's just I get what I get. And then this is next visit divided by the number of seconds.
What is the field class? Int length, or like what? Is it an integer?
So the field length, it's called days until next visit. So that's why I'm dividing by 86,400. Now I remember. I'm basically trying to make something that, I'm going with lead, I'm going and grabbing the next time that we see a patient, this patient, and then I'm going back and saying, okay, well, from this current visit, how long until we see this patient again, and doing the math between those two.
Is next visit a column? Or how do you get the value for next visit?
The prior column, it's generated on the fly. So the column above, so mutate, right? It takes whatever
Okay.
columns and it
I see
creates
it
new
now.
ones. Yeah.
Yeah, so where you see lead, lead is basically telling it jump to the next row and grab discharge date,
Okay.
and we're going to make that the value for next visit on the line we're currently on.
Okay.
The opposite of that would be lag if you wanted to go back one.
How is it specifying like which row to jump to for the next date? Or
First it is group, when it says group by name, that's the
okay.
way that I'm using. So I'm saying, when you see this patient, we're going to like group all these visits by this patient together, and then we're going to do that.
okay.
And it's already arranged in that order of visit date.
By virtue, yes.
Yeah.
That's really cool.
So it's kind of, like I said, a lot of things that I do end up being duct tape and bubble gum, but
If
they're
it works,
better
who
than-
cares?
They're better than nothing.
At the end of the day, your boss is not asking what function you wrote to get this, right? He cares that it's correct and that he has hands on it. Or
And
she,
I mean, the
sorry.
best thing is I justified two people's jobs. And it's helping people who need more care than just like treat and street get more care.
Mhm.
So
Is this suggesting more functions, helping suggest more functions for the CRC or more services that could be provided to the persons experiencing homelessness?
Ooh, good question.
for a lot of that, we rely on just kind of narratives from the CRCs, kind of what they're seeing. Like, part of this is what we send to, part of the actual pretty report is part of what we present to the donor who helps fund these jobs. But there's also, like, the story tells better than any graph is going to. So,
For sure.
you know, the person who we were able to get into substance treatment
Mhm.
instead of, you know, tweaking on Melrose or something. And so it's just kind of everything combined, but it's one of those, we can show the impact, that this has impact and it's worth keeping around. And hopefully by proxy, maybe me.
Nice.
But it's kind of one of those, when I left journalism, I was like, I can't like sell my soul and just work in like a job where there's not a mission. So luckily I found something that
Totally. Makes
Yeah.
a difference. Yeah.
I'm scared, but my wife has a question.
Don't be scared, man.
Being verified.
No, you shouldn't be scared. So I have a question about your markdown file that generates the final, like, quote unquote pretty report for the lay people who have no idea that this script is running all of that and your minds would explode if they saw it. Have you had to make any adjustments to make it easier for them to glean findings from it, or to make it easier for them to digest? I'm interested in the relationship between the UI UX and the actual the script.
Well, it may not be easy to, maybe if I zoom in, you can see like I've tried to bold the takeaways
Mm-hmm.
and also make the numbers that you really need to pay attention to as big as I can. So that's kind of my way of doing that.
Does this help balance the like work in conjunction with the narratives that you're getting from the CRCs about people's experiences, like mirroring the data with what people are actually going through?
I'm not in these meetings a lot. Often I'm just passing this off, so I don't necessarily hear a lot of those stories. But there's been a few times, like, you know, we've heard like, you know, hey, this person that's been here a cajillion times, like, is actually going in for rehab, and like they're giving it a shot, and like we will like all like if anybody kind of knows the situation, they will go around to the CRC and like, hey, congratulations, we know this was, you know, something that you had to push and push and push for, so nice job. And that's like one of the other things that I end up doing with my job a lot is things that, you know, we can end up kind of giving nurses and physicians who, at this point, you know, we've been talking about clinician burnout in the healthcare field for a few years, especially during COVID. And so it's one of those, you can point out the things that they're doing right and be like, hey, good job on this. So like, you know, doing reassessments in the waiting room while we have these buku wait times. So, you know, people aren't just decompensating and having somebody pass out in the waiting room. That's never fun. Whoever.
Are you augmenting the data set that comes from sort of internal organic sources with any third-party data sources, like maybe from Axiom or some other data vendor?
No, I'm probably not the best expert on healthcare data or HIPAA, and so I'm very like conservative when it comes to touching anything or marrying anything of ours with other tools.
Yeah.
Just basically, there are penalties for both the organization and for the individual. So, yeah, I'm just super careful.
Do the CRCs, are they evaluated in some of these metrics?
There have been times I think they've been kindly nudged, like, hey, you know, we saw you only did X number of visits with patients this month, or actually one time we discovered that somebody wasn't hitting like a certain box that would produce their name in the report, and so like a lot of their interventions weren't showing up, and so that was kind of, you know, looking back at that and seeing we didn't have a count for this new person yet, was like, oh, we need to make sure that, you know, you're hitting this part of the checklist as well, so that it actually is giving you credit for the work you're doing, because electronic health records are messy.
Mm-hmm.
I saw that you were using dplyr.
Mhm.
Is that for the amount of records that you start with?
Yeah.
How many records roughly?
Well, I also have one of the things that I use when I'm kind of joining things together is a master record of like every visit since 2020. So you consider about 85 to 90,000 patient encounters a year. You're looking at, God, I just asked myself to do math.
Might be a while.
Just round up to 100,000.
Yeah, a lot of patients.
Yeah.
Yeah.
Yep.
So, what's next step / long-term goal for this? Like, hire a junior data scientist under you to take this over? Because I'm sure new legislation is going to come down the pipe, and next, you're going to get pulled onto the next project, right? And the next thing, right? You can't be babysitting this, and I mean, you could probably fine-tune it to death. I think that's kind of the labor of love that comes with these kind of programs. But where do you see it going, and what would you maybe fantasize about long term for it?
I don't know if I necessarily like have a vision, but like wherever the I am more than happy to listen to our CRCs on where they want to go with it, and just whatever they say our patient needs end up looking like, and if there's a way to measure that, we'll bravo.
One more thing, sir. I'm sorry you mentioned it. How do you provide this? Is you give it as a PDF or you post it somewhere?
For some folks, I literally just send the HTML version, but some of them I also send the PDF. I throw the PDF in a box folder.
Okay.
Could you talk about how about Quarto a little bit? Like what part of your presentation is that? And
Yeah. It's actually, you can see, so the Quarto is basically, gosh, I know how to use a computer. So the only thing you're not seeing here that would be part of the Quarto is up toward the top there would be stuff that says like, title, CRC report, author Luke Morris, date modified, and then I tell it like last modification or whatever.
so what's the format that you used for these slides then?
That was actually, let me just pull up the GitHub. That will be easier, and you can see what they look like. So yeah, this is the only part that you're not seeing at the moment.
Luke, do you mind zooming in a little bit?
Sure.
Oh, thank you.
And when you go to the webpage for Quarto, it provides you with a lot of documentation to where you know what should go where.
Mm-hmm.
And also there's just a lot of cursing and swearing until it works.
How do you render it? Is it kind of like with the knit command in our studio?
Mm-hmm. Yep,
Okay.
instead of knit, you have a button called render.
Nice, okay.
And yeah, it's essentially the same.
Sweet.
It's the same. I might be wrong about this, but I think the same YAML header will work on a Quarto file, which is like a .qmd.
Mm-hmm.
So if you go in there and literally just replace your RMD with QMD, it might actually render.
Interesting.
I don't. Yeah, don't quote
I've
me on
only
that.
started with Quarto. It is wrought with peril, that whole YAML
really?
file. Yes. So
Okay.
I don't know about just changing
I'll be
that.
careful.
I have no idea.
Well, you need the Quarto CLI, so you need like to download the Quarto engine, and then there's a Quarto R package as well. So it's not just as easy as like
Okay.
just changing out RMD for QMD, but yeah.
Yeah, there was a little bit of toying around the learning curve.
This stuff right here is super helpful. I think they make it a lot easier in Quarto than R Markdown with Jarringan or the other extensions to it, where you can break out a column on a slide very easily just using this column width code. So here he's got the left column at 40%, the right column at 60%. Is that right?
Yeah, so actually this right here is all one slide. So we saw 40, I had if I go back, maybe I should have just done a presentation on how to do it. That would have been cool. But yeah, so this is what you're seeing, and this is what creates it.
I hear the presentation slot for June's open. So
I mean, eventually I will get to like presenting that in LP, but kind of want to, you know. And yes, I'm also the dork who like reads everything off the speaker notes, so don't judge me. Love you too, honey. But yeah, like, I'll definitely give you my card, and that way, you know, if you have questions, reach out.
Sweet.
So.
You might hear from my whole office.
there was also a presentation on Data Science Hangout like maybe 6 weeks ago, was it, Javi? A gal who did like how to do your resume super down and dirty quick using Quarto. And that was nice to just kind of, it was almost template style. And then you could switch out certain things to get a feel for where the features are located.
I'm really sick of Word.
Oh, and you need to discover Office R or Officer. Well, it's the same thing.
Oh.
Another package where you can make Word and PowerPoint docs on the fly. Yeah.
Thank you, Luke.
Thanks, Luke.
Hopefully I look like I know what I'm doing.